got some folks still grabbing lunch, so please do. There's lots of seats, so please fill in and find a place to settle in. I wanted to welcome you all. My name is Patrick Murphy, and I'm the Research Director at the Public Policy Institute of California. We're pleased that you could come today to talk about the healthcare workforce in a report that we have that we'd like to sort of share some of the ideas and then have a conversation about. So we've got an interesting panel for you. Part of my job is to get through a lot of the things to sort of give you a sense of PPIC as well as a little bit in terms of setting up the agenda for today. So first, in case you are unaware, the Public Policy Institute of California is an independent, nonprofit, nonpartisan research organization focused exclusively on public policy in California. We do a number of these events. This particular series is sponsored by the James Irvine Foundation. We're very grateful for them. They make this possible. They make it possible for you to join us for lunch, which is always a more pleasant way to get information, I think, somehow. Yay. And we are very pleased to have their support for our activities here in Sacramento. A couple of housekeeping factors that for some foolish reason they empower me to or entrust me to do. But just in case you don't know, we do this as a web simulcast, and we would ask that you turn off your cell phone, of course, because now we've got this technology that if it hears a cell phone ring, it zooms the camera in on that person. So, and if you don't believe that, just try. So anyway, that obvious reminder. The other is that when you came in and sat down, there was a couple of things on your chairs. One, an agenda for the day. Also, the report that we're going to focus on today, the health workforce needs in California. I did want to point out that we have another piece that came out, a current topic, that takes a look at sub-baccalaureate, less than a bachelor's degree workforce needs as well. As you can kind of see, they sort of telescope into one another. So we're going to focus more specifically on the healthcare element of it, but wanted to let you know that that piece is in there too, and also on the web, and I think of nice general broader interest. And then as important, you've got an evaluation. We're really about data at PPIC. We love our numbers, and we like to get feedback in terms of these events. So if you could make sure, fill that out. It'll only take less than a minute probably, and drop them off on your way out. That would be great too. Last but not least, the briefing slides that we're going to walk through today are going to be up on the webpage probably before you get back to your office. So if you don't want to take notes feverishly and try to do verbatim, as well as eventually tomorrow probably the video will be up, so you don't have to worry, you can relax a little bit on your note taking. I also wanted to plug a couple of upcoming events for PPIC in this room on September 30th. Sarah Bohn and Caroline Danielson's report, Child Poverty and the Safety Net in California, we will be talking about and providing a briefing on, and so I alert you to that. And then on October 6th, we're going to have a conversation with the leadership in the Democratic leadership over at the Capitol. Assembly Speaker Tony Atkins and State President Pro Tem Kevin De Leon are going to be in conversation with PPI CEO Mark Baldessari. That's going to be over at the Sheraton in the ballroom there. Slightly different lunch menu too. But if on both of those, if you could go to the webpage and sign up, we really appreciate it. It helps us on a number of fronts to keep track of who's coming and all of those good things. So with all of that behind us, I'd like to sort of move into today's program. What the plan is for today is that we're going to have a brief overview of the report and then a panel discussion about this issue, taking a couple of different perspectives on it. And then I will make sure, being a thoughtful, conscientious moderator, that there will be plenty of time for Q&A on both the presentation and the panel. I don't want to sort of break it up and get us going down a couple of perhaps cul-de-sacs on a couple of specific issues. So that's the plan for today. You can, if I don't do a good job right on that evaluation, moderator was lousy, and that's great. So today I'd like to get us started. As I mentioned, the report that we're releasing today on the healthcare workforce, written by Shannon McConville, Sarah Bohn, and Laurel Beck. The three authors are here today. We've asked Shannon to sort of kick us off and give us an overview of that. So Shannon, if you could do that, that would be great.
Hello, and thank you all for coming. First, as Patrick mentioned, I'd like to acknowledge my co-authors on the report, Sarah Bohn and Laurel Beck. Today, I'm going to be discussing results from our recent report on California's health workforce. PPIC has a fairly long history of work examining workforce issues in the state and the role and capacity of California's higher education systems to meet the state's workforce needs. With this report, we wanted to take a closer look at a particular segment of the workforce, that being the healthcare workforce. I should have taken a sip before I started. So the health workforce is a large segment of California's economy, accounting for nearly 1 in 12 jobs in the state. It's also expected to grow by more than 20% over the next decade. Our analysis of available state employment projections indicates California will add an estimated 450,000 health jobs by 2020. One thing to note here is that these are projections, and they are subject to a certain amount of uncertainty, depending on how economic conditions may change, and also given the evolving changes of the healthcare system related to health reform. Things could change, but right now these are our best source of information, and that's what we use in the projections for this report. Something that isn't uncertain is the fact that California's population is aging, and that will drive much of the growth in demand for increased health services over the next few decades. California's population over 65 and over is expected to increase by nearly 50% by 2025. With the largest increases among those aged 75 to 85, and we'll also be seeing large increases in the Latino and Asian older populations as well. Although many healthcare occupations require very high levels of training and education, there are still considerable opportunities in healthcare fields for workers with some college training below a bachelor's degree. For this reason, higher education institutions that provide associate's degrees and post-secondary certificates, including California's 112 community colleges, will play a crucial role in training workers. So here, this first slide, we show the occupational distribution of California's current healthcare workforce. It's the first pie chart in 2010, and projected new health jobs in 2020. So much of the focus when we talk about the healthcare workforce is on physicians and nurses, and for good reason. They provide primary contact and provision for much of patient care. Here you see doctors and other clinicians. In the other clinician category, we're including pharmacists, dentists, other highly trained clinicians, represent about 15% of the workforce. Nurses account for about another almost a quarter. But we see here that what we term allied health, technicians and diagnostic support and healthcare support, comprise over half of the health workforce. And among new health jobs, these are jobs created from new demand for services. We see an even larger share among allied technical and support, again, likely driven by the needs of an aging population. One final note that I'd like to make on this slide is you'll see we also include a group called therapists. These include physical therapists, occupational therapists, among others. And I should note that there's not necessarily a hard and fast definition of what constitutes the allied workforce. And in other studies and analyses, this group often is also included in the allied workforce. We did not include them as a focal point in our analysis because most require bachelor or master's level degrees. And given our focus on 2-year training institutions and opportunities, we chose instead to focus on technicians and support occupations. So here we're presenting the education levels of Californians currently working in allied health, technical, and support positions. And we see the majority of both occupational groups have some college training below a bachelor's degree. Technicians in diagnostic support has a larger share of those with associate's degrees, about 20%, compared to just over 10% in healthcare support. Well over a third in both groups do have some amount of college training, and this would include post-secondary certifications. Here I'll give some examples of what we're including in the technician and diagnostic support occupational category. It includes things like licensed vocational nurses, paramedics and EMTs, diagnostic sonography, and dental hygienists. Examples of healthcare support include certified nursing assistants, home health aides, and medical and dental assistants. And while you may think that many of the healthcare support positions do not require any college training, and while we do see about 35% have a high school education or less, some of the largest support occupations, including nursing assistants and medical assistants, do often require or prefer some post-secondary certification for employment. And you'll also notice that nurses are on this one as well. They're not considered as part of the allied health workforce, but we showed their educational distribution as well. We see about a third of working nurses do have associate degrees, but nearly 2/3 have at least a bachelor's degree. So now we move to the projected needs, the projections for the future health workforce jobs and the training that they may require. So the first large bar represents that projected number of 450,000 healthcare jobs. This is comprised both of the 200,000 new jobs generated as the result of increased demand, as well as the 250,000 jobs that will be required for replacement needs. So this is replacement of current workers that are leaving the labor force, oftentimes due to retirement. The need for replacement workers, I'll note, is particularly high among certain health occupations, including those that are more highly trained, doctors, other clinicians, but also nurses as well. The orange segment of the bars indicates the proportion of the workforce that we estimate needs some college training below a bachelor's degree, and that's based on the current educational attainment of the current workforce. That's where we get those, how we estimate that. The gray part of the bars includes all other levels of education. That includes both those with a bachelor's degree and higher, but also those with a high school education or less. So if current trends hold in the educational makeup of these occupational groups, about 38%, or about 190,000 health jobs, will likely require either an associate degree or post-secondary certification. And we see the largest segments of those among technicians and healthcare support occupations. I'll quickly note, too, one place where maybe current trends might be shifting could be amongst nurses. There have been calls, particularly by the, or most notably by the Institute of Medicine, to have more nurses have bachelor level training. And so in the future, we may be seeing some shifts in that occupational distribution by education. So in order to meet the needs for this nearly 200,000 health workers that will likely need some level of college training, our state's two-year institutions, predominantly California's community colleges and private for-profit institutions, are going to be an important component. This figure shows the number of completed associate degrees and certificates in health programs at California institutions. Certificates include awards of less than a year and those awards that are between 1 and 2 years but less than 2 years. We see much of the growth over the past decade has been among private institutions. And here I'll say that private institutions do include both nonprofit and for-profit institutions. But among sub-baccalaureate degree completion, more than 98% of the sub-baccalaureate degrees, and here I mean the associate degrees and the certificates, are being completed at for-profit institutions. So that really is the sector that is in the sub-baccalaureate degree production for health programs. We see the largest growth in certificates, although associate degrees at for-profit institutions also did grow considerably over this time period. We see slight increases at public institutions for associate degrees, but those largely held steady. But there is some growth there. And so when we think about available educational opportunities in health training programs, it's important, obviously, to consider the health workforce needs of the states, including the long-standing policy goal to diversify the healthcare workforce to be more representative of the state's population as a whole. But it's also important to think about the needs of the students enrolled in these programs, both in terms of providing educational opportunities that are both accessible and affordable, and more importantly, can lead to well-paying and stable jobs with career opportunities and growth. And I'll note that healthcare occupations often are held out as a very good example of an industry or a field where there is opportunity for career ladders and for growth amongst occupations. But in order to kind of better understand things, we need to understand what types of degrees students are completing, and that's what we take a look at next. Here we've provided a bit more detail on the types of degrees completed in 2012. This is the most current data we have available. We've grouped them into some broad occupational categories and divided them by public and for-profit institutions. We see that public school associate degrees, I'll note that the public school associate degrees are all completed at community colleges. Public school certificates, about 80% are completed at community colleges. The other 20% are completed at adult vocational education schools. Here you'll see that nursing represents a large share of the associate degrees that are completed at public institutions. There are very few associate level nursing degrees completed in the private for-profit setting. Public institutions also, again, confer 2-year certificates or less than 2-year certificates, with most of these being in technical fields, such as EMTs. That's one of the larger degree completions among certificates at public institutions. And while we saw from the previous slide that the private for-profit sector has increased its production of associate degree in health fields, the bulk of degrees are certificates that take less than 2 years to complete, and most are in healthcare support fields, most prominently medical assistants. That seems to be where the bulk of degrees being completed at for-profit institutions is. And those, we provide a little bit more detail in the report, have relatively low annual earnings. And so next we turn to the students who are completing health degrees in the state and what some of these trends might mean for them. So here we're showing the distribution of completed degrees. This is both certificates and associate degrees, by where they were completed, whether at a public or a for-profit institution, by the race and ethnicity of the students completing them. And while it's not shown here, when we look at just the total number of completed associate and certificate degrees in health programs, broken down by the racial ethnic background of the students, there's very good representation of Latino and Black students completing health degrees relative to their makeup of the college-aged population in the state. But when we take a more close look at the types of degrees and the settings where they are being completed, we see that nearly 3/4 of sub-baccalaureate health degrees completed by Latino and Black students are certificates at for-profit colleges, with much smaller shares of associate's degrees being completed at public schools, where costs of the health programs are considerably lower. This raises some concerns that perhaps students' interests are not being as well served as they could be, and that underrepresented students in particular may not being well served by the public systems in their health programs. And so kind of to conclude, in order to ensure that the state has an adequate supply of allied health workers with the correct occupational mix and that's adequately distributed across the state, requires considerable planning and coordination from a whole group, a lot of different actors, both state-level actors and regional actors, workforce and health planning agencies, employers, and education systems. So there are a lot of folks that are working together to make this happen. Fortunately, many collaborations already exist, and people are doing a lot of work in this area to meet the health workforce needs of the state. One thing that would be helpful, more data and information is needed to effectively plan and then monitor how these trends are changing, and that needs to be high quality, it needs to be timely information, and it would be helpful if it could be linked across certain things. And so you have the Office of Statewide Health Planning and Development, often called OSHPD. They do have a health workforce clearinghouse where they've assembled a lot of the available information, but improvements could be made in terms of consistency and accessibility and also the timeliness of that information. There's also considerable work that's being done by UCSF, as particularly in the area of nursing, and they do produce that quite often, but more efforts such as those will be very helpful in ensuring that the needs are met. And then with regard to for-profit institutions, the federal government is providing or trying to provide some enhanced oversight. There are some new gainful employment regulations that are still being negotiated. And what that really comes down to, both at the federal and the state level, is the important thing is that students are provided with good and accurate information about the costs of the program and also the opportunities for employment once those programs are completed. And that's where a lot of the efforts are focused. And finally, we discussed, given the large community college system in the state, 112 community colleges well distributed throughout the state, serving more than 2 million students, they really represent an important opportunity as a training ground for people and an affordable training opportunities. But it's likely that they might need more steady sources of enhanced financial supports for in-demand health programs and more knowledge and understanding what those in-demand programs may be in these different regions, and also keep a focus on expanding access, particularly for underrepresented students. And so with that, that's the overview, and there's more information provided in the report if you'd like some more in-depth. And now I'll go back to Patrick to welcome our panel.
If the panelists could come up, that would be great. Thank you, Shannon. When we embarked on this work, the idea was to start a conversation about this need. And we thought, what better way to start a conversation than start it with a conversation? And so the work that Shannon presented, I think, is a jumping off point, but it takes place at a certain level. We're looking out in the future, we're looking across the state, and we feel like it would be sort of a nice way to complement that would be to sort of take it down more to the ground level, as it were. And so, as Shannon alluded to, there's a number of different actors that are already involved in this. It's not as though as of September 19th, this has been discovered. Folks realize this is out there, and they've been working hard. We thought we would sort of bring you a little bit of insight into that. And so we've put together a panel today that consists of, and I'm just going to introduce, on the back of your agenda, you can have the full bios of the folks that are participating today. But in the interest of time, I just want to let you know, we have Sarah Bohn, who's a research fellow and economist at the Public Policy Institute of California. Sarah works on workforce issues, and in some cases, particularly looking at the role of community colleges, and also a co-author on the report. Catherine Martin from the California Hospitals Association is the Vice President for Workforce. If you go to her webpage, you will find that she has written and spoken on a number of different times about workforce issues, particularly from the perspective of a big chunk, of course, of the demand for this, the hospitals associations. And then Dr. Jocelyn Garrick, who wears a number of hats. Today we're going to tap particular expertise. Dr. Garrett is the director of the Alameda County Health Pipeline Partnership. The partnership's a consortium of pathway programs designed to increase the diversity of the healthcare workforce, and very precisely one of these programs that's already sort of up and out there and has been trying to address some of the issues that was raised by the report and by Shannon just now. So I think the most sensible place to start is that we are at that sort of top level, and I just wanted to ask, maybe start with you, Dr. Garrett. Sort of, does that ring true? And we're sort of projecting out in the future, and you're looking at it from a slightly different perspective, but I wanted to give you a chance to sort of give a sense of the future as you see it in the needs for the workforce.
Well, thank you for having me here. And can everyone hear me? Okay. And thank you for your report. What resounded for me in the report was the dichotomy between the for-profit and the public institutions in Alameda County. I have most of my data. We're finding that there is a break in the pipeline. Students primarily go to the for-profit institutions because that's what they're familiar with. That's what their cousin, their aunt, their grandmother, their mother went to, and they're not getting informed when they're in high school or community college about opportunities that are available through the public sector. We're also finding that most of them then go into debt and don't secure a job. We know that there is growth, but not in every health field. And most of our students are going to MA. But in Alameda County, for example, it's challenging to get a medical assistant job. If you're willing to go to Coachella Valley or Orange County, maybe you can, but then you have hundreds of students with debt who aren't getting employed, and they don't know about nuclear medicine tech as a possibility, or ultrasound tech is still hiring, or get a CNA, and then you can move on to be an ED tech, and they're still hiring. So I think the opportunity is in high school and community college. Community colleges, luckily the federal government, because of the Obama plan, they have released a large amount of funding opportunities in the state of California. Is going to receive some called the Career Pathways Trust. For the last year and a half, people have been scrambling across the state to apply for funding. In Alameda County, 2 of our community college districts did receive that funding, and it is in essence to expand the certificate programs for high growth fields at the community college level to balance that for-profit versus public. I know for health, they will be focused on EMT, MA, and some of the radiology tech careers. That's a step in the right direction. Diversifying the health workforce obviously is what our program is focused on, and to have the wraparound cultural appropriateness to it. The data I'm sure, shows that if you have a Cantonese speaking, provider who's working with the Cantonese patient, they're going to have better outcomes. So we need to ensure that we are culturally appropriate and we're reaching the communities that we need to reach. That's pivotal.
Thank you.
You're welcome.
Ms. Martin, could you kind of give us a sense from the hospital associations and your members?
Sure, and thanks for inviting us to be here. It was good to see a more updated report. These things come out from time to time, and this one's the most recent. So when I first saw the number that you were predicting, I was very taken aback by that. So I think it's very consistent with what CHA has been seeing over the past 6 or 7 years. I will say, though, that in the past 6 or 7 years, there have been immense changes in the healthcare industry, and for hospitals in particular, and that change has been dynamic and fast and uncertain. So what I would add would be that I think Shannon touched on it in her remarks. She mentioned, she gave us that qualifying statement of, this is just a prediction. So many things could change, and that's exactly true because. What I've learned about workforce planning and development in the healthcare sector is that it is no longer a numbers game. Supply and demand is one piece of a very complex problem that we have to solve. And now we have to layer on top of that the implementation of healthcare reform, emerging technologies, new reimbursement models, and in addition to that, you have a real focus and a push toward team-based care, so that we have a healthcare team working together in ways that they never have before, and that might require looking at scope. So you have all of these downward pressures on trying to figure out the health workforce, and they're all moving at a very rapid pace, and so it makes it very difficult to say exactly what we're going to need. We're talking a great deal with our members about the healthcare workforce of the future and what those skills and requirements might be for individuals. And the one thing that is very true is that it will be a requirement for all healthcare professionals to work at the top of their scope and to also have very solid, what we're calling now 21st century skills. In the past, we've called them soft skills, but I think we've sold them short in calling them soft skills because they aren't soft skills. They're skills that people need to have in the healthcare workforce. So there's numbers game is important, but we have to be cognizant of all those other factors that are going to really impact what it is we need. And then regional, of course, and I know that Shannon understands that. This is a statewide report, but each region is going to be different. And we know for a fact that the rural regions of our state, that's where our hospitals are really suffering at all levels in terms of workforce recruitment and retainment.
Could I just ask you to talk about the top of the scope, just to explain?
Well, you can be licensed many times in California. We have certain regulations that inhibit an individual from practicing to the very top of their scope, what they're actually licensed and what they've been trained to do. So we need to look at so there may be scope issues where folks are unable, certain professionals are unable to work at the very top because of certain state regulations. But then we also may have a need for expanding some scope. We look at this in laboratory quite a bit for MLTs here in California. It's an associate level degree, but we have a significant laboratory workforce shortage. It's our highest demand occupation, and we're not going to produce enough clinical laboratory scientists to fill that role. So it's really important that we look at the technician level, the professional level that Shannon mentioned, which is the associate degree less than a bachelor's degree, to see how we might be able to get these folks to support the laboratory in new and different ways, recognizing we're never going to have enough CLSs because we just don't produce enough, and that's a baccalaureate plus a year of hands-on training, so it takes a while to get there. So scope can be two ways, working to the top of your scope, or in some ways maybe we need to expand scope, depending on the profession.
Sarah, I want to give you a chance to chime in because we've got the sense of a lot of things at stake, a lot of moving parts, so we're doing a little bit of crystal balling, but maybe you could elaborate a little bit on that and maybe start to talk about some of the things maybe that the community colleges could offer.
Right. I think pulling back a little bit and thinking about the workforce skills gap in California more broadly, I think what we found in the healthcare workforce separately is consistent with a lot of evidence that PPIC has been looking at for years on just the trajectory of educational attainment in California and the trajectory of economic demands with regard to skill, where more and more jobs of the future are requiring more skill, even within jobs that used to not require training past high school, now require some. And so when you think about those numbers and those trajectories, what we projected is a shortage of 1 million workers with a bachelor's degree by 2020. And then what the second report that you were given today looks at is the kind of gap for those with some college, so with an associate's degree or certificate, those workers that Shannon was talking about is possibly even larger, about 1.5 million worker shortage. So I think what the challenge is meeting that kind of large scale of increasing our capacity to train people in California. And that brings up a host of issues that are well known, I think, with our public higher education system, and particularly the community colleges.
So have set up this gap, both for sub-baccalaureate, for less than a bachelor's degree and beyond in general, specifically in the healthcare workforce. And I sort of feel now that maybe if either of Dr. Garrett or perhaps maybe we'll start with you, Kathy, some thoughts of programs that might address this or ways in which we could do it. I'm always self-conscious. We always sort of say, wow, there's big challenges out there. But I do want to be able to highlight some of the things that are being done and maybe even touch on some things that could be done.
Mm-hmm. Yeah, I would definitely say that and we've talked about this. It's funny that you brought this up because we've been talking in the meetings I've been in the past couple of days about the skills gap and how healthcare is changing so fast, and how will we, as a state, and so that means all stakeholders, produce that workforce of the future. And the one thing that is true is that we have to look at new and innovative ways of training and educating. And that probably will mean more attention to those 21st century skills. But it also is going to mean we might have to look at delivery of education and training. Mm-hmm. You know, how we're doing it. In many cases, the way we're training healthcare workers is the health workforce we needed 40 years ago, not the health workforce we're going to need. So it's always been my message, and we do work very closely with the California community colleges and the CSUs on this issue because we care about the allied health workforce so much. But we're transforming as an industry. We need you to look inside your walls and transform with us because you're the producer of our future workforce. And you know, to touch on the private piece of this, that is everything that Dr. Garrick said is very unfortunate, and our industry hates to see that when that happens, when students graduate with large debt and can't find jobs because there's misalignment. At the same time, there may be some who aren't as bad actors, and as an industry, we are disheartened when we have to necessarily look to the private sector because they're more nimble, they can change quicker, they engage industry earlier in their curriculum development so that the curriculum is really aligned with what the employer needs, whether that's 21st century skills or whether that's health professions competencies. So I think we're trying to send that message. So when you ask what are we doing to do that, we are working very closely with the publics because we want them to transform along with us.
I think along with what you're saying, that employers need to be at the table. A lot of our discussions are with policymakers and the schools and the educators. Our community colleges and high schools need to know what skills the employers want, and we can't hypothesize about that. They need to be at the table so they can tell us what they need and inform the training. So there needs to be a direct link with our major systems, whatever they are. And in my area, it's Kaiser and Sutter and the large community clinic consortium. But if the employers are at the table, and apprenticeship programs is, I think, a solution. If we go back to what we did in the 40s and 50s, my grandfather told me, you know, he got his trade in high school, and now we are going back to that model. It also helps with exposure. You get the opportunity to get exposed to the field. You get the clinical hours that are needed, and then the employer can see who they like, who's a good fit, and hire you. I'll give you an example. In our area, which also touches on scope, which you were mentioning, traditionally a community health outreach worker has a bachelor's degree or master's. In my county, in our civil service process, you actually need a master's degree to be a community health outreach worker. You do health education. We started a pilot through a funding from Robert Wood Johnson to say we're going to take a high school graduate who has either an EMT certificate or not, and train them for 5 months to be part of this health home, which is huge. So the Obama plan says that we've got to do prevention. The United States is at the bottom in developed countries for health delivery, and we spend the most money, but we have the worst outcomes of any developed country. So what can we do? Well, prevention is key. Most of our money is spent on people with chronic diseases. 5% of the people in the United States with chronic diseases like renal failure, heart failure, cost us the most. 5% cost us the most money. So how can we keep those people healthy or prevent heart failure, prevent renal failure? Part of that health home may be just a prevention worker to make sure you understand in your Spanish language, in your Mandarin language, in culturally appropriately healthy nutrition. So we just started that program in March, and the outcomes are phenomenal. It touches on scope, though. We have 18 and 19-year-olds following patients, meeting them in their home, accompanying them to their doctor's visits, teaching them how to ask questions and advocate for themselves. It's an entry-level career. Of course, I'm biased as a physician in health, but when you work in the health field, you can start off like this. When you're in the hospital, you're seeing nurses, doctors, PAs, ED techs. You're mentoring and networking with a host of other careers that could lead to then vertical movement within this health system. But health education traditionally, as I was saying before, has been done by nurses and nurse practitioners. That may affect scope. Are those nursing associations comfortable with a high school degree certificate delivering this service? The wonderful thing is with the Affordable Care Act, they're offering new reimbursements because they're focused on prevention for things like health education. So I think that's my spiel.
So if I'm getting it right, the pipeline kind of plays producer, and they bring the students, the training, the potential placement together, in which otherwise would be kind of left to happenstance to
Right. We play
find
a
the
dual
path.
role. Like PPIC, we try to collect data. The Health Pipeline Partnership in Alameda County looks at labor workforce. We work with community-based organizations that serve students in our area, primarily high school and college, that may want to go into a health career. And then we tell them, these are the careers that you should be exposing your students to. And then we try to create new pilots, like an EMT training program, to say, in our area, EMTs is in demand. So in our area, we advocated for our programs and spoke to the EMS agency who was having an RFP as another example. Can you write in your RFP to include preferential consideration for students that graduate from this EMT program sponsored by our Health Pipeline Partnership? But the employer was at the table to help make that happen.
which also brings up back to the surface to this regional variation that
Right.
we have going across the state. So Ms. Martin mentioned the notion that the private for-profits are real nimble to respond or whatever. And as a former university faculty member, you know, not-for-profit, private, or public, the last thing that faculty members want to do is change. But maybe you could talk about some of the other things that might stand in the way of, say, the community colleges being able to respond to these.
I think this data here shows just who is really filling the gap in needs, and it was the for-profits in this sector, and they are a lot more flexible in a lot of ways than our public institutions. There's a couple things. I think the big two topics that we think about are access for students to community colleges and their success in getting through, and these are kind of two of the hurdles. And there's been a lot of talk and policy work and discussion and efforts to improve on both of those fronts. In particular, with regard to access, the Career Pathways Initiative that I think Dr. Garrick mentioned is one to try to provide more funding for programs that are in demand, because the funding system of the community colleges is really on a per student basis. But a lot of these allied health and other technical fields that are in really high demand for our economy are much more expensive to provide. So on a per student basis or a student hour basis, I jotted down the numbers for myself. A respiratory care course costs about $260 compared to a humanities course, which would cost us $52 for the same student hour. And so the funding, which is provided just on a per student basis, not on a basis of the cost of providing in-demand programs, kind of provides a disincentive for colleges to offer more of those classes. A real one, because they are continually hitting budget constraints, and we saw that in stark relief during the recession and the budget crisis, and the 2-year kind of low in participation rate among students in the public community colleges. So I think that's one of the big hurdles that the state needs to address if it really wants to be the actor that helps kind of meet the need of our future workforce through its colleges. The funding is one of the really big issues there.
And the access to the classes, that was a key point about 2 or 3 years ago in our data, that students were leaving the public system and going to some of the for-profits because they couldn't get the classes because of capacity. It's also on the university level for our Cal State system and our UC system. Many students were having delayed graduation because they weren't getting into the classes because classes were cut. So that's also increasing debt because it's another year or 2 of trying to stay at the university.
And with the added challenge of classes need to be sequenced,
Right.
so it's not only if I can't get in this semester, it means I can't just jump to the next one. I've got to
Right.
wait till I get that.
Right.
Go ahead.
I just wanted to add a piece of good news or something hopeful to think about of the efforts to increase nursing training through the community colleges over around 2005 through 2009 was really successful. It increased the number of nursing students enrollment, I think, by about 75%, and it grew the number of programs by 35 programs across the state, and I think really helped address the nursing shortage. Now, other things are going on as well. There are macroeconomic conditions and other things that drive those as well, but I think there's reason to hope that we can increase the capacity of training in in-demand fields through public and private dollars and partnerships in the colleges.
Ms. Martin, I was wondering, maybe you wanted to touch on some examples that you might know of in terms of, say, hospital partnerships or ways to address some of these?
Well, you touched on one, and we can talk about some others, and I think we need to even keep working at this with multi-stakeholder models. But the Nurse Education Initiative, you're right, was very successful, and it was funded by the governor's discretionary dollars under WIA. So, and then it involved, then you pull in the employers, Sutter being a big one here, and then you pull in City College and their nursing program. So it was a very diverse partnership, multiple sources of funding that were able to really, at least for this region under the Nurse Education Initiative, really bring up the numbers in terms of nurses. And I think we need to look to that model in the future, because the truth is all resources are diminishing from every level, whether you're talking about from the employer perspective because of our uncertainty in regards to reimbursement and declined census in our hospitals because of the recession. And the WIBs, of course, have suffered their cuts. The community colleges, you mentioned that's true. So with all of us working with less and less, we have to collaborate more and more and begin to coordinate and leverage resources. So I think that I think we're doing a good job. I can say for sure that we are doing better now than we were 6 years ago. 6 years ago on the State Workforce Investment Board, there was not a single person representing healthcare. Now there are 3. So we're moving in the right direction in terms of engaging employers in various agencies where we typically may not have had representation before. So we're certainly moving in the right direction. I sit on the Health Workforce Development Council, and that is a good example of a state body that has multiple agencies involved, multiple employers, not just hospitals, because I'd like to emphasize that the job growth in the future will not be in the hospital. It will not be in the acute care setting. It will actually be in ambulatory. And that could be a hospital system's outpatient clinic. That might be the case, but certainly we've seen over the last 10 years, job growth is outside of the walls of the hospital, and if we do the Affordable Care Act right, that should continue. So certainly that's a good body where we do a lot of collaborating around resources and strategies and plan to continue that, our work with our partners in that way.
I think the WIBs have done a great job as well to leverage philanthropic organizations to support this work. And we've noticed in the last few years alignment from our funders to address this issue and help us to fill the gaps.
So we've got providers, we've got philanthropic, we've got public institutions, and then we've got two big populations. And one of the pieces that comes out of the report is if you sort of secondary. Not only is there this big challenge, but then there's trying to get all those pieces to align so we get the right match. And I'm wondering if somebody could speak to that. And I want to start. Actually, there's a couple of mismatches. I want to start with the jobs that are in demand and having people trained for that, because obviously that is a goal of what you'd want to happen. And right now, one of the pieces that came up was that we're training a lot of people, but not necessarily for the right jobs.
We saw a lot of this under ARA. So there's a lot of federal restrictions on money that comes out of the Department of Labor that causes and this is no fault of the WIBs. They're trying to work within the parameters of the funding that they've received, but you can't call it money for high growth, high need sectors such as healthcare and call out healthcare and then expect somebody who requires a tremendous amount of remediation to be trained to go into a healthcare job that's in demand in 18 months. So unfortunately, many times the WIBs have to sort of do what they can with the population that they serve and still meet the obligations of their funding, of their funders. And that is a mismatch and an alignment issue that we have grappled with for years. We're hoping under WIOA that will change. So with the reauthorization of the Workforce Investment Act, now called the Workforce I think Innovation and Opportunities Act, I got to take investment out of it. We're hoping that will change, and some of those federal restrictions will actually allow the WIBs to do that type of training and get incumbent workers, address some of their skill gaps, do some upskilling for those workers to get them into higher wage jobs where there is tremendous demand.
So provide the resources, but also the flexibility to do the matching.
Yeah.
And then we go back to see regional variations, I suspect, as well.
Yeah, and that may look different for every region. And for the WIBs who serve more than just our sector, they may not have a priority around health. Most of them do, but they may not, because another industry may be their primary priority, just depending on where they are as a region.
Sarah, Dr. Garrett, do you want to add?
I will add, just to comment on remediation, that's one of the key pieces to improving student success in community colleges that I know the Chancellor is focused on, and there are a lot of other efforts underway to try to improve successful outcomes through the community colleges. I think a lot of students come in without the adequate preparation to actually prepare in a short time frame, and so ensuring that students get the basic skills that they need is one key piece. I would say that another key piece is that students have the information to best understand what the job outcomes are from various training. And I would like to say that the Community College Chancellor's Office, I think, has made really great stride in providing that information. They have this Salary Surfer functionality on their website where you can look at what actual students who came through various community colleges and with different degrees are earning. And I think that's really a step in the right direction, and we need more of that kind of information and ensure that it's getting into the hands of future students.
So the second mismatch that I was hoping you could touch on from the panel is this notion that we know the population that's going to be in need of services is getting more diverse. That as we watch our population age. But again, we don't know if we're going to have a workforce that's going to be as diverse to address some of the cultural competencies and other challenges that come with that. And the pipeline project, I know, is explicitly directed towards that. And I'm wondering if there's sort of other ways to either think about it or other examples that we can look at so that we're getting the diversification in the workforce that we would want.
It's information, exposure, and then a holistic approach. It's what was mentioned as far as the soft skills, if you want to call it. But to be completely transparent, most of our programs standardize a healing and a mental health. For first-generation students. Not all students from different ethnic backgrounds, but especially our first-generation students, our immigrant students, they need different approach with the wraparound support to build confidence, hope, motivation, mentorship. They need to see people that look like them, and they need to have a sense of purpose and acknowledgement that they deserve to be there. So we implement life coaching through all of our programs and healing circles that are centered on African American history, Latino history, Vietnamese history, with mentors that look like them. And then we have, 100% success for those first generation students because they have a sense of purpose and mentorship, and then they could achieve any goal. And I don't know if that can be amplified at the community college level, but we are asking that they consider that piece, whether it's trauma-informed care, whatever the buzzword is now, but that just addressing the personal mental health of the students who, from some communities, are experiencing stress, depression, and extreme home situations that are preventing their academic success.
So beyond just the classes
Yes.
in the classroom,
Yes,
in the training, but realizing that you're going to want to do more, provide more,
right.
and then in turn get better success rates
Yes.
as well.
And for CHA, we partner very closely with CalHOSA, which is Health Occupation Students of America. We work very closely with them. There are about 4,500 HOSA member students. It's actually a grade 7 through 14 program, so it crosses over into post-secondary. And when you walk into a HOSA conference, you see the diversity of California right there. And it's one of the reasons that we partner closely with them, because these are the students who have already shown an interest in healthcare, and they're getting the leadership skills that they need and that we want as employers. And if we can keep these students in the system and in the pipeline and give them the support service, which I completely support, to keep them in and to get them into licensure, all the way through to licensure, they will go back to their communities and practice. They will represent the populations that they've served. So we definitely partner with them. It's part of the California Department of Education, but it's the California chapter of a national organization. So that's kind of the work that we're doing around diversity. And we've also partnered with the California Endowment before, a few years ago, on a grant to help support programs that are aiming to increase diversity in the health professions. So that's, from our perspective, that's kind of where we've been focusing.
Well, I think maybe this is a good spot to expand the conversation. And just to a little logistical thing, we've got 2 microphones that are coming in, and because we're broadcasting this on the web and we'll be taping this, if you could wait till you get a microphone in front of you to ask a question, that would be great, because that way we can hear and others can hear too. And so I've got one right here in the front row, and we'll start there, and I'll try to sort of balance off.
Howdy. Thank you so much. Micah Weinberg with the Bay Area Council Economic Institute. A quick comment and then a question. And the comment is that we hit on scope issues. I did some research on this topic this year, and one of the things that may be depressing the growth of some of, in particular, the higher skilled folks within the healthcare sector that we need, such as advanced practice nurses, are our outmoded and unscientific restrictions on people practicing things they've been trained to do. And so states that have modernized their scope of practice legislation actually have more advanced practice nurses because they want to practice there. So making these scope changes not only helps us with being able to deliver healthcare more efficiently, but it keeps us from pushing away the people that are really at the center of our healthcare system going forward. The question is, how did you come up with your estimates? That was the one thing that was kind of missing for me. You've got this, 250,000. Is that an estimate of what you expect the need to be, or is that an estimate of what you expect the job openings to be? And how did you come up with that estimate?
Go ahead.
Yeah, it's based on employment development data, and so I believe those are, and Sarah actually, I think, did most of those calculations, and so I believe those are jobs. Is that?
There's job openings, and then there's also the replacement. There's the new jobs, and then there's the replacement jobs, which is the total number of job openings, and that's behind. That's the 450,000 estimate, half of which is coming from new job growth, and about roughly half of it, or a little bit less than half of it, from replacement needs. It's purely based on the EDD projections.
Right, their occupational
projections,
projections, like the BLS does for the national level. EDD takes those BLS occupational, they have a big occupational matrix where they're looking at different things and skill, and then projecting out what demand and other things may be, and then EDD kind of adapts those to what they know about California through different methodologies. And so those are largely available on their web, and we use those.
So generally, it's taking historical growth patterns pretty much, and that's the downfall to that. There are other ways of estimating, as I'm sure you all are fully aware, using more econometric models and theoretical kind of equilibrium kind of status. But we just kind of kept it simple with the official kind of EDD estimates.
I'm going to wait to get the microphone. Ms. Martin, I don't know if anyone wants to comment on are we behind in terms of updating our scope?
Yes, CHA supported all three scope modernization bills by Senator Hernandez. So yeah, I would say definitely. California has, not just on those three occupations that were part of that bill package, but we've got some issues around CLS as well that I hope will be addressed in maybe the personnel regs that will be released hopefully sometime soon. Because certainly, around CLS, we've got a couple of issues too, keeping people out of the state. Education requirements that are very, very outdated, not necessarily scope per se, but courses that we require, but the rest of the country does not, things like that. So I agree, yes, we do need to modernize scope. And California we think we're special, so we have all these different
very special.
Yeah, we are special.
We've got a question here.
I have a comment and a question. Ms. Martin, you mentioned that made a surprising indictment when you said that job growth is outside the hospitals, and I see hospitals shrinking and transferring duties from allied health workers to nurses. I also see that there's a bankruptcy in the system, the healthcare system, two types of bankruptcy. One is fiscal, the other is moral. The fiscal bankruptcy indictment came on the Diane Rehm show last January, and it was an interesting statement by two representatives, one from the Kaiser Health Foundation, the other from Robert Wood Johnson Foundation, both of which are heavily invested in healthcare research. And they said that these two spokespersons said that it's entirely possible this is the last gasp for private healthcare in the United States. And then secondly, it's morally bankrupt because when we wring our hands and say, gee, we have all these chronic diseases, we have the asthma and we have the inflammatory diseases and on the rise and kidney disease and so on, and yet we don't realize that our diets are killing us. And there's a movie that just came out with Katie Couric that's called Fed Up. I recommend that you see it, and it talks about how deadly sugar is to the portal system of the liver, and this is morally bankrupt. This is morally bankrupt as antibiotics were back in the 40s and 50s.
Though you have a workforce question?
Yeah, it has to do with whether or not this system is sustainable. I don't see it as such. I'm 4 years out now, a graduate of the American River College Respiratory Care Program, and there is the little training that I received, in clinical, could not be transferred over to the hospital. And the hospitals have no internships. There's no opportunity for me to work. And it's like, I have a license. I have credentials. I have advanced credentials. And I can't work. And I see this whole system collapsing. I think you're trying to fix something. I mean, maybe the question is, I don't think this is fixable. Do you?
I would say that we are definitely in a period of transformation.
Yes.
And we are moving from providing treatment to managing care.
Yes.
And we're here, and we're in an old paradigm of healthcare delivery that definitely needs to move into the future and transform. I would agree with you, and that is the transformation, to move from acute, episodic, fee-for-service system to hospital delivery care where we are managing the care of humans. So I would agree.
I completely agree. I agreed with some of your comments, and I look at it the lens another way, it's an exciting time because so much has to be done and there's so much opportunity right now in health workforce. We do need everyone to play fair in the sandbox, at least most people to get in the sandbox and play. If we do that, then we can change the system, and we have best practices outside of the United States. The internships, the lack of them, as you mentioned, just like the classes, it's a huge issue, but I think that can be fixed if we get policymakers, employers, and the students' representatives at the table. I do think that can be fixed. It has to be fixed, or that you won't get to the goal.
No question over here. Oh, right there. You've been waiting.
Yeah, one of the things that the ACA brought us was expanded coverage in the behavioral health area, including substance abuse treatment. And I know community colleges and universities have addiction studies programs in place and career ladders in place. And I just wondered, is this the kind of academic program that you mentioned, like respiratory programs that cost a lot of money, or basically I just wondered if you could comment on what we could do to increase the education in that particular workforce.
That's huge right now, and Ms. Martin can probably comment as well. We can't touch on everything in 40 minutes, but along with the Career Pathways Trust, the federal government is infusing millions of dollars into mental health, direct services, as well as careers. And most of those careers under the CPT funding will be at the community college, and they're partnering, I know, with county public health departments and behavioral health departments to create the internships and align for the jobs. Because we didn't mention, we also know a lot of the chronic diseases have comorbid conditions that are mental health, and some mental health conditions lead to other conditions. So they're intertwined. So they're trying to be comprehensive and address both.
Yeah, and from behavioral health, I'm not an expert in that particular area of workforce. However, I will say that, I do know that OSHPD has been working very hard on their 5-year strategic plan for workforce and education training in mental and behavioral health. I believe they have some funding to do that as well, and then some of the money from the Mental Health Services Act has now been moved over to the Health Workforce Development Division of OSHPD to do that work. So it is very important. There are extreme shortages in that area. So it should not be overlooked.
Question right at the back.
Good afternoon, and I'm really glad to have this esteemed panel here. I'm a consultant and a researcher, and I study workforce trends and demographics. And what I'm wanting to ask you is about with respect to with the education, because I go in a lot of the schools and I really try to assess how their curriculums really fit. And particularly when you're talking about ethnic populations in our urban cities with schools, there definitely is a underserved area of need to really try to work to get students into these disciplines, particularly when you're talking about ethnic minorities, African Americans, and Hispanic populations, and not having the exposure, learning early on, not just at high school, but even in elementary education, to get them exposed to getting into health, medicine, the sciences, and then also where you see the trend with competing other disciplines of getting students with that. And then one last point, how do you see the workforce going with rural areas, and what are the needs there for meeting those needs? Thank you.
I can try to address the first part of your 3-part question, which was education and dialing lower down, like to middle school and grade school. And in Alameda County, we try to inform the teachers who are working with our health academies so they know what careers are out there. We also now work with them over the summers on their curriculum, so that they are able to teach the students at a younger age. We did a report on boys and men of color. We did a focus group about 4 years ago, and that focus group found, we did it for one reason. We have about 1,100 students in Alameda County that participate like in a health exposure program, and 80% of them were female. So we said, well, where are the boys and men? So we held a focus group with like 56 of them, and they, we asked the question, well, why aren't you participating? They gave us many answers. One of them, they felt a health career was feminine. They thought of nurses, and then they thought doctor, that took too long. They needed some cash immediately, not to stereotype you, but that was one of the needs. So informing them that it's not just doctor, nurse, there's a host of careers like sports medicine and occupational therapy and physical therapy that are actually dominated by men. They don't see them. So helping the teachers with that curriculum and bringing the employers that I keep going back to form alliances with these schools so that their employees are exposed to the students.
Yeah, allied health is one of the hidden professions. I mean, it's just, students do think about doctors and nurses, and there are many stereotypes that go along with their perspectives there. So we try to do a lot of work around career exposure through CalHOSA, through some other work that we do. And then your last question about rural, yeah, I would say that our rural hospitals are struggling the most when it comes to workforce. I know that, you know, there's been a lot of work and messaging around the new grad issue and nurses not being able to get jobs, new grads. And all of our hospitals are still in need of experienced and specialized nursing staff. But our rurals are that really never happened. They still continually struggle to recruit and retain nurses at all levels, and then in all areas of the hospital. Pharmacists, CLSs, we have rural hospitals who've been searching for a CLS for over 2 years. It's very, very difficult to attract people to those very remote, geographically isolated communities, and then to top it off, if they were going to grow their own, there are no programs there to do that. So it is certainly something I worked on it previously to even coming to CHA as the executive director of the California State Rural Health Association, and so we're perfectly aware of it, and boy, some of those hurdles are big. Some of them are big.
Question here.
Hi, my name is Susan. I work for OSHPD Clearinghouse, so you know, you guys probably use some of the data. My question is about, you know, the broader workforce labor market has a problem of underemployment and also employers having a bias against workers who have been out of the workforce, you know, due to whatever reason it might be. I was wondering if that has played a role in the healthcare workforce, the supply, and how this might affect, you know, the scope you're talking about. If you want to have someone who is a high school graduate and having them certified for certain things, where before you might need to have a master's in that degree to work in the same job. So if any of that might apply to the healthcare workforce and policy recommendations on that, perhaps.
So is that for the researchers, or is it for me? We could go.
I suspect we'll get both takes.
Okay. Why don't you go first, Sarah?
I'll just mention what I know about underemployment, and it's certainly true that while our labor market conditions have improved quite a lot, we're not even back to where we were before the recession started in 2008 in terms of our unemployment rates. And then that doesn't even count the folks who are not employed full-time, who are still looking for work or underemployed in various ways. But I do know that a lot of the employment growth that we've seen has been in health sectors. And so I haven't looked at the most recent data, but I would expect that there's probably less underemployment or unemployment there, but it's still certainly an issue that the recession raised, and just the level of training needed for the jobs of the future and our ability to retrain workers, to help them upskill, and to connect workers with job opportunities that are not necessarily in their immediate areas is definitely of big concern in just kind of getting our labor market going again. But with
And I'm glad that you brought this up, because I wanted to make this point earlier, and it slipped my mind. But I think what the recession taught us, I mean, it was a big wake-up call, and it was a lot of message managing that I had to do at that time, which is healthcare was thought to be recession-proof, and it's not recession-proof. We found that during the recession. While we were a sector that may have added jobs, keep in mind hospitals did reduce workforce as part of their cost reduction strategies because they had to. And the health sector in general is more than just hospitals. We're a large employer, but and have many employees, but we're not the only employer. So when you look at, okay, well, the health sector added jobs, it may have not been us. That may have come from others. Employers. So we learned that we weren't recession-proof, and then we don't need as many folks, and so maybe some people were laid off, and are they coming back into the market to get to one of your questions about how employers see people who've been out of the job market? That's the first time I've heard that for my industry. Most of the time, if our members have a position open, I mean, they equally vet their candidates and pick the most qualified. I've not heard any biases towards folks who have been out of the workplace, at least for my industry. That's not anything that I've heard of. The bias that we hear mostly is the new grads. I mean, if you have somebody who's experienced, not somebody who's been out of the workplace per se, but somebody who just never even got in, the new grads, you do hear that, certainly, but you have to think of an employer's perspective. You've got an experienced nurse versus a new grad. You're going to make that decision. So.
Got a question at the back, and then we'll.
Jocelyn mentioned an 80% women in one of the programs that you ran, and I didn't know if in this study you did anything about a gender breakdown of what the students are and the employees are.
Do we have gender? I'm getting shaking heads here.
No, that was one of the dimensions we didn't choose to focus on.
We're at 50% now. 50. It's equal now.
This gentleman right in the middle there. Furthest from you.
Hi, my name's Brent, and I'm a career counselor by trade, and I'm looking to transition into healthcare career advising. So I have a couple questions or just things I want to know for my own good. One, though, is a friend of mine who's a nurse actually got his degree from a community college. He applied to a federal hospital institution, got the job, went through the background check, and for whatever reason, his accreditation didn't meet quite the standards of the federal hospital system. So I'm wondering if there's a disconnect there. That's one thing that I wanted to know a little bit more about. Secondly, there has been talk about internships and sort of, Dr. Garrick, you'd mentioned life coaching and mentorships. And what do you think the role is, or maybe the growth area? I know that, so for example, like UCSF, they have a career center. Stanford Medical School has a career center. But other med schools, it's kind of few and far between. We're also talking about, the community college level and, internships and trying to have organizations set up, partnerships with those schools. What do you see the growth like in terms of career advising or career specialists helping these students make the bridge, get the internship, such as this gentleman here, to have that less of a struggle? Do you see a growth area there?
It's a gap, and it's actually there's a group in my county, again, is my knowledge, called Urban Strategies Council, and they're funded, someone mentioned the California Endowment, they're funded by TCE under the Building Healthy Communities Initiative, and their main goal now with the Aspen Foundation as well is a one-stop re-engagement, they're calling it, center, and they're looking for what you're describing, to identify these students, to advise them properly, and then refer them to the high-growth sectors, not just healthcare, but construction, marketing, etc. But that I know in my county, that's what they envision as a solution, one of the solutions.
From a matching perspective, helping folks get into internships and what have you, we think of intermediaries as doing a good job of that. There's been some computer-based work in that regard in the Bay Area around nursing, so that if somebody needs a clinical placement and a hospital's looking to fill a clinical placement, there's an electronic way to make that match happen. It's very isolated to the Bay Area. And then recently, LaunchPath here in this region was launched, and that is also a high school and post-secondary internship matching through the Community College Foundation tool and portal, so that employers are looking for interns and interns looking for placements can match up. It's just, again, it's regional. So when you ask if there's going to be growth, I would imagine that would be great if there was something statewide. Because the truth is there may not be enough placements in a region, regardless of the profession. And that, I think, is part of the problem with the new grad situation with nurses. Nurses are not willing to leave. There's jobs, but you may have to go to Modoc, or something like that. But it's the part about not wanting to leave your region. And maybe if there was a statewide mechanism or portal to do what you just described, and people were willing to move or relocate, which I know can be a huge undertaking, then there might be a possibility to make more matches. I know you had another question too, and I can't. Oh, the nursing, the license. When you say federal, you're referring to the VA?
Yeah.
I can't speak to that. I'm not sure. I'm not sure what that. I don't know what their licensing requirements are for that particular hospital segment.
The VA is not. They won't accept anything but something.
Yeah, it's different than the BRN. Yeah.
But you have to show them your actual license.
I've got one here, and then I'm bouncing back and forth to keep.
Good afternoon. I work at the Health Professions Education Foundation. We're a nonprofit housed within OSHPD, and we provide scholarships and loan repayments to students and current health workers who commit to working in underserved areas throughout California. So I wanted to ask you all if you could talk a little bit about how financial incentive programs can help meet some of the health workforce needs and gaps.
Your program is phenomenal, and we love you. I just want you to know that. And we market what you do to all of our students and our teachers because I know the focus today was on allied health, but not only for allied health careers, but even more for the health professional careers. It is costly to go to medical school. The average debt now is $300,000. And your loan repayment program allows some of our students to say, okay, well, I'm going to get the 4-year degree because I know I'm coming back to my area to work, and most of those areas are in underserved areas that qualify for your program. So it helps us diversify the workforce and not limit them to certain careers, because some of the careers, because of the loan debt, it is a barrier. But that program helps. I've seen, it's not just anecdotal, students realize they can get the loan repayment, so they go on to the PA, the nurse practitioner. They go on to medical school.
And I've got the last question that we're going to do right there.
Okay. Hi, my name is Sandra Perez. I'm with the Senate Office of Research. My question is under the umbrella of recruitment and retainment. And it parallels the behavioral health question. Are students or is there any incentive to become specialized, say, in aging issues, serving the aging? We're talking about the aging population and its contribution to the demand. And also, are there other specializations where in-house staff are given, and there's no employers at the table, but are they given salary increases for maybe being specialized in IT and health records or interpreting services if they're bilingual? Are they paid a little bit more? Because we're talking about, like you just mentioned, the loan repayment program. I mean, and at a very smaller scale, for those incoming entry level, maybe they need some sort of an incentive too. And I just wonder, does that exist? Or is there any talk about that? But particularly, are there any specialization programs for the aging, to serve the aging population?
Not that I know of.
Yeah, I'm not aware of any. Again, I don't spend a lot of time in behavioral health, so it wouldn't be surprising that I may not be aware of them, and they may actually exist, so I'm not sure.
Aging.
Oh, aging, but okay, I thought you mentioned mental and behavioral health, and okay, I was thinking, and then taking that and specializing in aging. Oh, are there any, so programs specializing in like geriatrics and things like that? Well, I know that there's a nursing program, I believe it's in Monterey at CSUMB that has a program that is focused on nursing for an aging population. I'm sure there's others. I think it's probably, I don't know outside of nursing where that might be, but it's probably a gap. It probably is a gap because the population that will be cared for and it will be the aging population. They will be the high utilizers. So it's certainly a gap. Regarding employers and incentives to take on specialized work, each employer decides that independently. I know one of our larger systems does for the bilingual skills that you mentioned. They offer tuition reimbursement so that native Spanish-speaking employees, so incumbent workers, can get training in medical terminology, because just because you speak Spanish fluently doesn't mean you speak medical terminology, and they do offer up skills and pay increases for those skills, and there's a couple of levels that you can go up, but each employer designs those programs separately.
Well, I'm going to wrap it up. What I will say is that I don't know about a couple of our panelists. I know our researchers are going to be able to stick around. I'm going to sort of identify Laurel Beck, the third author that you haven't quite seen, but feel free to ambush her with any questions you have about the report. You can thank me later. I want to thank you all for continuing this conversation. I hopefully it will continue going forward. You've made a great contribution to what we were trying to get at with this. And then I want to thank our panelists and Shannon McConville for today. For taking the time and coming up here and sharing with us your particular perspectives on this, because I think that's the real value added. And then last but not least, if you could fill out your evaluation, that would be great. There's a basket there. Upcoming events, www.ppic.org. Please check it out. Thank you.